Now, moving on to our next section, that is the distal 1/3 of the humerus fractures. In this section, we'll be discussing the pathophysiology and associated injuries, the prognosis and classifications for the distal 1/3 of the humerus fractures, what are the imaging techniques, and what are the options we can have regarding the distal 1/3 of the humerus fractures. As you know, the humerus is mainly divided into the proximal 1/3, the middle 1/3, and the distal 1/3. Distal 1/3, it has condyles called medial and lateral epicondyles as well, in which it forms a joint with the trochlea, and the elbow joint as well is formed between the radius and ulna. Now it consists of a supracondylar fractures, that is just above the condyles and the distal 1/3, or it is a single column condyle fractures, which could be in form of medial condyle or a lateral condyle fractures. It could be bicolumn fractures involving both the condyles, that is the medial and the lateral condyle, or it could be a coronal shear fractures, which is usually seen in the sagittal view, that when you are viewing it from the side, this anterior posterior fracture which is running through and through, not going upwards and downward, is usually viewed on the lateral view as well. If you see on the X-ray, when we are viewing the AP and the lateral way, we have to see different things, but where the fracture line is exiting, whether it's where is the radiocapital line, where is the anterior humeral line, which can be seen in this diagram, and where it is going through the capitulum or not. Epidemiology, usually the distal intercondyle fracture, the most common fractures was the humerus fractures. Most commonly in young males, it's associated with high energy trauma, and usually older females, actually it is secondary to trivial falls, because they may be associated with a lot of osteoporosis, and fragile bones get fractured easily using falling the trivial trauma. Coming to the pathophysiology, the mechanism could be low energy fall, especially in the case of elderly, or it could be high energy impact, especially in the case of younger population. Now, coming to the pathanatomy, this could be due to elbow position affects the fracture type, whether it's extension type or a flexion type energy. If its elbow is less than 90-degree flex, that is mostly it means that it's extension type kind of injury. This will axial load will lead to transcolumnar fracture, that is through and through the columns, both columns would be fractured. Or it's a direct posterior blow which leads to olecraneal fracture without the distal humerus involvement. In that case, it will be extension type of injury. But if the elbow is flexed to greater than 90-degree, this would result in flexion type of injury, which may lead to intercondylar fracture as well. That means both the medial and lateral condylar fracture along with the intra-articular involvement as well. In this case, usually there are a lot of structures which are going through the elbow. There is a brachial artery, there is median nerve, there is ulnar nerve, which is just going through the medial epicondyle. So there may be associated with a lot of other injuries as well. Most commonly, it is usually associated with elbow dislocation. There is called a cerebral triad, which is actually associated. This is called as if this is this dislocation, the radial head fractures along with the capitulum fracture is called as the cerebral triad of the elbow, and this is actually associated with poor prognosis. There may be floating elbows, that is there is supracondylar fracture, the humerus, and distal radius ulnar fracture, which may need basically associated with polytrauma. Or if you see this, there's a shaft of humerus fracture and olecraneal fracture as well. This is a classical example of floating elbow. Or it could be leading to Volkmann ischemic contracture. This is usually results in there was a polytrauma, there was multiple injuries, and massively a hematoma formed, and which really compressed the brachial artery. This leads to kind of a compartment syndrome of the forearm, which was missed, and eventually leading to Volkmann ischemic contractures as well. Now, coming to the prognosis, majority of the patient regains 75% of the motion and the strength. And our goal is to go for 30 to 130 degree of flexion. Usually unsatisfactory outcome is in 25%, and either the associated injuries are so much, there is highly comminuted fracture, they may be associated with elbow dislocation, or there may be a terrible triad like this distal humerus fracture, radius ulnar fracture along with the capitulum fracture. So when there is complicated fractures, you usually have a less favorable prognosis, but most of the time it has a good prognosis. Treatment may be complex. Why? Because the way the fracture pattern presents to us. It could be a low fracture line to one or both columns. It could be metaphyseal fragmentation of one or both columns as well. Now, if there's highly comminuted metaphyseal fragmentation, this means it was a high energy trauma. It could be an article combination. The more the article combination is, there will be increased chances of post-traumatic osteoarthritis and eventually will require replacement of the elbow. Or it could be due to maybe the poor bone quality, which may be associated in the elderly females, especially when they are having an osteoporosis. The classification system, there are multiple classification systems as well. Most commonly is the OTA classification of distal humerus fractures. Humerus is named as bone 1, this radius ulnar bone 2, femurs 3, and tibia is 4. So its proximal humerus is 1, 1. If its mid shaft humerus is 1, 2, and distal humerus is 1, 3. Then you gave it type A, B, and C. So if it's a type A fracture, which is actually extra-articular, mainly involving the metaphyseal region, so it would be 1, 3A type. Then it further subdivided into 1, 2, 3. That is, it's one single transverse fracture, slightly comminuted, or highly comminuted. Then it would become either 1A1, 3A1, 13A2, or 13A3. Similarly, type B means intra-articular single column. Either it's the medial column or the lateral column. In that case, it becomes 1,3B1, which is only involving the lateral column, 1,3B2 involving the medial column, and if it's involving along with the combination as well, it becomes 1,3B3 as well. Now, type 3 is actually a kind of a intra-articular, both columns are involved with a comminuted fracture as well. And once intra-articular involvement is there, it automatically becomes 1,3C, further divided into C1, C2, and C3. The greater the combination of there, eventually it will become 1,3C3. Now, Milch classification is mainly reserved for the children fractures, especially the distal humerus fracture in the case of children. Milch type 1 is actually lateral trochlear ridge is intact, and the fracture is actually a lateral to the trochlear ridge. Well, in case of Milch type 2, it crosses the trochlear ridge and goes medial to it, and eventually it forms a Saltaris type 4 injury, while in the case of Milch type 2, it's mostly Saltaris type 2 injury. The geometrical classification is also basically a kind of a geometrical classification for adults as well as the children. It gives you a brief classification system for the geometry of the fracture is. High T type means it's a T-type fracture, transverse fracture humerus and upper olecranon fossa. Low T-type would mean a very small T-type fracture. There will be Y-type fracture, H-type fracture. Medial lambda is then the lambda-type configuration with exiting out, a line exiting out of the medial condyle. Lateral lambda is a lambda-type configuration of fracture and line exiting out of the lateral condyle. Or multiplane T-type means in which there is a fracture in the anterior-posterior as well as medial-lateral plane as well. Now, coming to the clinical presentation. Now, if you see, the symptoms would include elbow pain and swelling. On physical exam, there will be gross instability, which often be associated with polytrauma because are a terrible triad because there is massive disruption of soft tissue. Usually, the range of motion may be due to decreased range of motion, may be due to the neurovascular insufficiency. So we have to examine the neurovascular structures as well. Neurovascular structures has a lot of nerves and arteries are going through the elbow, such as the radial nerve, median nerve, as well as ulnar nerve and brachial artery. So we have to check for all these nerves along with the brachial artery in form of distal pulses. Brachial artery may be injured, and if pulse is decreased, obtain a non-invasive vascular studies that we have to go for first. We have to confirm whether is there a complete laceration of the artery or is the hematoma which is actually pressing the brachial artery and there is actually no associated injury. So we have to go for vascular angiogram. Once vascular angiogram is given, then we can proceed for the surgery actually. And we have to monitor carefully for the compartment syndrome because the fracture would produce swelling and swelling would eventually lead to compartment syndrome. And why it is important? Because Volkmann ischemic contracture can be disastrous, which produce permanent disability of the patient. Now you see the imaging, first you have to get the x-rays. First and foremost is the x-ray of the elbow joint, AP, and the lateral views. If you see it over here, this is the fracture line going like this, and probably it's a supracondylar low transverse type of fracture with probably another fracture line exiting right over here on the medial side. So it's kind of a medial lambda type fracture. Both columns were involved, therefore just fixed. If you see this is probably the fractured low T type kind of a fracture. There is a transverse fracture which is also involving the intra-articular fracture as well. So other option, if it's highly comminuted, if it's suppose AO13C3 type of classification, then we may require CT scan with 3D reconstruction to know what is the how much restoration or reconstruction can be done. Especially why we need MRI sometimes because when the high energy trauma, maybe associated elbow dislocation, or in case maybe associated with terrible triad of the elbow, in this there is massive soft tissue injury, and later on there may be gross elbow instability, so we need to get an MRI. So what are the soft tissues which we need to repair, especially to restore the elbow joint? Other x-rays, if this is also a low T type fracture, this is a Y type fracture. If you see this fracture line is exiting like this is a highly comminuted fracture. This is also a Y type fracture. This is comminuted type fracture. If you see, this is 13C1, that is, it's involving the metaphyseal as well as the articular region. Now this is C2, that is slightly more, the articular segment is slightly more comminuted. C3 means the articular segment is highly comminuted. There are multiple small fragments which we cannot, probably difficult to reconstruct. In this section, we have briefly gone through the what are the signs and symptoms of distal 1/3 of the humerus fractures. Usually, we must be sure that it's isolated injury or not. It's associated with elbow dislocation, terrible triad of elbow, or maybe associated with other neurovascular injuries as well. There are multiple classifications in children. Usually, the Milch classification presents, and other for the distal humerus, we have AOTA classification and Jupiter classification. The mechanism is such that most of the time we have to go for, if it's associated with polytrauma or floating elbow, we will have to go for fixation. Most of the distal articular fractures, as they're intra-articular, they require open reduction internal fixation most of the time. Thank you very much. Keep watching sqadia.com.